Kuminori Taniguchi from Tottori University. So, it's okay.
And I'm Linda Judice from the United States.
So, today the three distinguished speakers will present the three good topics, I think. So the first presenter is Dr. Kaori Koga from Japan, the Chiba University. Okay, let's begin.
Thank you for your kind introduction, Chairperson. Good afternoon, ladies and gentlemen. It is a great honor to be here and make a presentation in such a wonderful conference. And I would like to thank the organizing committee for inviting me and giving me this opportunity. My name is Kaori Koga. I'm from Chiba University, Japan. And I'm going to talk about best practice for endometriosis surgery to improve fertility. I have no COI. So let me introduce clinical practice guideline for endometriosis in Japan. So there are 22 clinical questions in total, and 5 CQs are related with infertility, and 3 CQs related with infertility and surgery. So I will introduce these 3 CQs one by one. So one CQ is CQ10, reads, is surgical treatment for deep endometriosis effective in improving fertility? And the answer is surgical removal of deep endometriosis may improve pregnancy rates. But after my talk, or after the third speaker, Dr. Roman, will maybe talk about deep endometriosis, so I wouldn't go in detail here. The next CQ is CQ11, reads, is surgical treatment effective in improved fertility in infertile patients with peritoneal lesions? And the answer is surgical removal of peritoneal lesions improves pregnancy rates, but it doesn't really help. And in text, it's a description saying, however, the benefits of surgery do not necessarily outweigh those ART, as the presence of mild endometriosis cannot be determined until laparoscopy is performed. So it's true. So I would explain detail in later on. So the last CQ is my topic. It's surgical treatment for endometrioma or ovarian endometriosis effective in improving fertility. And there are 2 answers. Number 1, surgical treatment for stage 3 and 4 endometriosis, which means endometrioma, patient with endometrioma, may improve fertility. And number 2, removal of endometrioma does not improve pregnancy rate via ART. So I will go this in detail. So in addition to the CQ, 22 CQs, this practice guideline has overviews and algorithm for infertility and pain. And this helps a lot in addition to these CQs. So I will introduce this algorithm. Oops, I go too fast. Okay, so this is, sorry, this is very too small, but this is my favorite algorithm for treating infertility-related endometriosis. And this algorithm was actually, I was in charge in editing and writing. And actually, to tell the truth, this was adopted by the similar figure published in Nature Review articles, published in 2018. And at that time, I was a co-author of this paper with Becca, which is next speaker. And at that time, I was also in charge in writing this algorithm. And I remember there was a huge discussion over the algorithm, which comes first and which comes next. And this discussion is really helpful for finalize this algorithm. So I adapted this algorithm to this clinical practice in Japan. So I must say thank you for Chris and other co-authors to help or contribute this discussion to this Japanese guideline. So let me go through one by one. So first, you may ask the age of the patient. And if the patient age is young, in this article, we chose age 36. So if the patient is younger than 36 and there is no problem in her ovarian reserve and fallopian tubes and male factor, then you can try to see the natural conception. And if you wait for 3 to 6 months and they cannot get pregnant, then we go through laparoscopy. That's a recommendation. And once the laparoscopy has done, you may score EFI or endometriosis fertility index, which tells you the probability of pregnancy after the laparoscopy. And according to this result, you may consult with your patient, and if the patient wants to go ART or ART immediately, maybe you can transfer the patient to ART clinic. And if the patient wants to stay for a natural conception or general infertility treatment, then you can wait for another 3 or 6 months. So scoring EFI is very important. Okay, so if the patient age is 36 years old or more or higher, and the patient, or even though the patient is not advanced age, but the patient has the problem in her ovarian reserve or fallopian tube or her husband's semen problem, then you can consider about the ART. But before they skip to ART or ART, consider whether the patient has pain or the endometrioma, which should be performed surgery. And if she has no pain or no endometrioma, then you can go straight to ART or assisted reproductive technology. So that's easy. But the next flow is most complicated and difficult part. So if the patient has severe pain or endometrioma, which seems to be problematic, then you should consider laparoscopy prior to assisted reproductive technology. So let's take a look closer to that flow. So maybe there are 2 options. Number 1, straight to ART, or number 2, surgery first. And we are all struggling in these 2 options. So if you choose number 1, straight to assisted reproductive technology without ART, without surgery, the problem is if we go straight to ART without surgery, the cyst is still there in situ. And if you take the oocyte and doing fertilization and transfer the embryo, she has, even though she got pregnant, but she has endometrioma. And that sometimes causes problems such as persistent pain or infection or obstetrical complication, which is always like disaster or headache. However, if you choose surgery prior to ART or assisted reproductive technology, you may cut the cyst, which is good because there is no worry about endometriosis-assisted problem. However, once you attempt to oocyte pickup, you may notice that the ovarian reserve is no longer there. So there's struggle. So now we established the idea of ECBS or embryo cryopreservation before surgery. So ECBS, we would take the oocyte first when the ovarian function is full, ovarian function remains, and do in vitro fertilization and get blastocyst, and that we cryopreservation of the blood cyst, and then we do laparoscopy to remove the ovarian cyst, and then the patient without endometriosis, we transfer the thawed embryo. That makes the problem is solved. So the next question is how many eggs you should restore before surgery. And when I was in Tokyo, I conducted a study to try to find out the number of the embryo which we need. And the number was 5. So in conclusion, in this topic, so ECBS is recommended unless the patient has endometrioma that interferes with the oocyte retrieval. In that case, you have no choice. You need to do laparoscopy. And it is desirable to freeze at least 5 embryos before performing laparoscopy. So sometimes it's difficult. So if we plan laparoscopy, say May, but if we can't get enough number of embryo, maybe we need to postpone until we got enough number of embryo. But this sometimes happens. Okay, so last 10 minutes, I will talk about surgery. So again, I learned that there are cases that we need to do laparoscopy for their benefit or like inevitable reason. So when you do surgery for this scenario or this situation, we should keep in mind that surgery prior to ART or during infertility treatment, that kind of laparoscopy is fertility-sparing surgery. And it's not complete surgery. So that's something we really need to keep in mind. So it's not cancer surgery, so you don't have to remove the lesion completely. Sometimes you need to leave the lesion there and then keep the fertility. That's a priority. And in this context, I would like to introduce the idea saying invagination therapy or invagination theory, which is, so the endometrioma is not arisen inside the uterus, but from outside the uterus. So once the endometriosis, the tiny, tiny, small initial endometriosis happens, which happens between the outside ovary and peritoneum in the pelvis. And then that invaginate, not into, but from out layer of the ovary, and the ovary kind of like distorted and outside in. So it's not inside ovary, but the outside ovary. That's you should be remember. So because if you cut, or during the surgery, if you lysis, the adhesion between the ovary and the peritoneum, you always see the leaking from the content. And we call it rupture. But this is not the rupture. This is just the unplug the plug between the ovary and the peritoneum. So it's something we should be keep in mind, so invagination theory. And when you look this closer, so what I want to say here is that oocyte or the follicles or primordial follicles always locates just surface or cortex of the ovary. And this is not only here, but also, as I told you, it's not inside, it's outside. So the cortex or the layer of the primordial follicles are not only the outside, but also like inside, seems like inside, but not inside. It's still outside. So what I want to say here is your cyst wall is very close to the surface of the ovary or the cortex or the follicular layer of the ovary. So if you remove the ovary, the chocolate cyst in the proper plane, you can survive the follicles. But most of doctors or surgeons I saw misunderstand this layer. So they play in the wrong way. So if you go this red line, you will lose half of the follicles. So if you remove, if you remove this part of cyst wall, then you will lose the follicles. So that's something you should remember and don't misunderstand. So this is a typical specimen which was taken as a cystectomy, but this is typical misunderstanding. So here you see a lot of follicles. So this is not oophorectomy specimen. This is cystectomy specimen. But you see a lot of follicles in macroscopically, but also if you look at under microscope, there are a lot of like primordial follicles. So that's something surgery which was done under misunderstanding, typical misunderstanding. So the ideal or right plane was here. So it's really thin and tiny. So this should be removed, but other pinkish part shouldn't be removed. That's something remember, sorry. So keep in mind that the cyst wall is always thinner than you expected, and the right plane is always closer to the cyst wall than you expected. So do not drive into the ovary. So most of people dissect not between the ovarian cyst and the ovary, but between the ovary, and then tear the ovary in half and half. So don't dive into the ovary. And also, if you are in the right plane, bleeding will not occur. In other words, if you see the bleeding, you are in the wrong place. Another important thing you should remember is hilum, which is a danger area. So normally it's a place of proper ligament, which has ovarian vein and artery, and always there is a place where the fibrosis is so strong. So if you try to remove this part of the lesion, you may cause bleeding. So do not attempt removal in that area, and you use coagulation instead. So maybe you should cut it in the middle, and then the left region can be coagulated. And you should remember that fibrotic tissue is stronger than the vessel, the healthy vessel wall. So do not force tearing. I saw many young residency tear the tissue, to right and left. Otherwise, the bleeding occurs. And always remember that you are performing fertility-sparing surgery, not complete surgery like cancer surgery. So I will show another 3 minutes the video. So now I normally cut the wall by not the coagulation, but the scissors to see the right plane. And you see, the left side is a cyst wall, and the down is the ovary. So the cyst wall is very thin. And when you, in the middle, try to closer to the cyst wall and make the ovary thicker. Otherwise, and if you are in the right plane, there is no bleeding. So if it's undealt, not sure tissue, recognized as an ovarian tissue. So then sometimes you make a hole of the cyst wall, but it's okay. And if you see the bleeding, which means you are in the wrong place, and coagulate quickly, and then go again the right place. So if you go through, then you dive into the ovary, and then cut the ovary in half. And when you go to hilum, so always hilum comes very last. So here's a hilum, and at this moment it's dangerous to peel, so cut. And don't worry about the leftover, so you can coagulate later. This is another. So recently I used Da Vinci or other robotic surgery, so it's much easier to control the arm and scissors. And again, cut, not bipolar, not scissors, and not electronics, but scissors, and find the right plane. And again, the cyst wall is always thin, very thin, and ovary is always thick. And as you see, so imagine this is 2D, but when I saw under 3D, you can see the follicles. Oh, yeah. So if you see follicles, so that's ovary. So don't dive into the ovary, but so go through the follicles. So according to the Da Vinci or other robotic 3D high resolution camera, you can even see the pre-antral follicles, so you can avoid the wrong misunderstanding way. All right, so I would like to say the surgeon's responsibility is to avoid the reduction of ovarian reserve. And these are take-home messages. So laparoscopy may be less effective than assisted reproductive art. However, case exists where laparoscopy is required. Laparoscopy is benefit, or laparoscopy is inevitable. And an efficient combination of assisted reproductive technology and laparoscopy is recommended. And careful surgery may minimize the ovarian reserve reduction. So I would like to thank all members in my university, OBGYN team, and also here are the guidelines editors for Japanese one, including Dr. Taniguchi, who is chairing today. So thank you for your listening, and I'm happy to take your questions.
And thank you for great presentation. Any other comments or question? Here, please.
Ettore Ciccione from Bari, Italy. Just a little question. Do you have experience with laser treatment?
Laser, you mean
Laser.
CO2 or
For
other?
CO2 or other kind of laser in order to reduce the damage to...
Good question, good question. So I personally don't use CO2 or other laser or any like bubblization system. I normally remove, but some people do laser, and there is a discussion, maybe the CO2 or other laser or bubblization type is good for avoiding the damage. However, the recurrence rate may be increased. So it's always balanced between like completeness versus preservation of the ovarian function. But yes, the bipolar or laser bubblization is a good idea. And also, personally, I don't use CO2 laser, but I personally use the bipolar. So the tiny tissue which are left for the film, I wouldn't remove and then do. Sometimes I leave it, but sometimes I coagulate by bipolar. Thank you.
I'm Tom from Vietnam. What is the role of sclerotherapy? Sclerotherapy, is there any role?
Thank you for your question. You mean the like ethanol sclerotherapy or yes? So again, personally, I don't do, but some people does, and I read some paper from China. I think has a good result for. Again, so it's balanced. Maybe the completeness is weaker, so the recurrence rate may be higher, but just prior to assisted reproductive technology and just retrieve oocyte, maybe later on you will do like oophorectomy, whatever. But the tentative treatment or management, sclerotherapy is one option. Thank you.
I'm Tom from Vietnam. And what do you think about sclerotherapy by suction, washing, and then?
Oh yeah. So I think still in Japan, like Dr. Fukui is not here. Someone does that way, especially for like IVF clinic where the laparoscopy facility is not available. Do like during the or before assisted reproductive technology, do some like local anesthesia and wash twice, 3 times, and then put ethanol and then wait for 20 minutes something. And if it really depends on the operators, if it's like leakage happens, that may cause like chemical peritonitis. So we have some like cases from other clinic after the sclerotherapy for ethanol, the leakage caused disaster. So we personally don't perform, but that if the technique is okay, maybe some patients benefit that way.
Okay.
Thank you.
Hi, I'm Dr. Michelle Gamboa from the Philippines. So I understand that there's no cutoff for doing surgery in endometrioma. But in your presentation, you just mentioned large endometrioma. So I want to know what's your cutoff?
Great question. There is a huge discussion regarding the size. Recently, Dr. Collins from Belgium published a paper. It really depends on like the surgeon's preference, also the background of the patient, so how old she is and how AMH levels are, and how soon she wants to have baby, or how other factors are affected in terms of the infertility cause. So it's not really clear cutoff. But according to the Conics data, Like no one do surgery 2, 3, 4 centimeters, and everybody do surgery 8, 9, 10 centimeters. So between 4 and 7 centimeters, it's really debatable, like controversial. There's no clear cutoff. No one. Yep.
Okay. So it's time to call the next speaker. So thank you
Thank
for
you.
trying a very difficult issue.
Thank you
Thank
for
you.
your attention.
So I'd like to introduce the next speaker, Professor Christian Becker, who is from the Department of Women's and Reproductive Health at the University of Oxford. And he will be speaking on evidence-based management of endometriosis.
Thank you very much. Thanks for the invitation. So these are my conflict of interest, if anyone is interested. None of the proceedings went to myself. They all went to the University of Oxford. So why do we care? Well, because we think that, at least with a best guesstimate, that about 1 in 10 women during reproductive age are affected, which would translate roughly into 190 million women worldwide. But not only the numbers are of interest, also the effect it has. So this is from the Global Study of Women's Health from quite a few years ago now, where it already was shown that endometriosis has a significant impact on the quality of life, and in addition, also an effect on the efficiency at work or in daily life activities as well. So we have this unlucky triad of a high prevalence, reduced health-related quality of life, and reduced productivity. So when I was asked to talk about evidence-based medicine, I assume this was because I was involved in the ESHRE guidelines, which were published in 2022. And I will use this to give you an idea of what the evidence is like. Now, one thing that we all have to be aware of when we think about the guidelines that are out there, the guideline is only as good as the evidence that we have available. And what I want to talk about today is the effect of the quality of the data, the quantity, how transferable are the standards that we recommend, and is it accounting also for the heterogeneity and the biology of the disease? So let's first talk about the quality of the data that was available. I think we need to be certain that we understand that opinion does not equal evidence. We all are, well, a lot of us are surgeons, and we have very strong opinions about this. That's probably why we became surgeons in the first place. But that does not equate to proper evidence necessarily. And as you are probably aware, there's this classical pyramid of evidence base where we think expert opinion has the lowest quality, and then with case reports, case control studies, cohort studies, and eventually systematic reviews, the quality increases. That's how we usually see it classically. So for the ESHRE guidelines, there is a guideline how to write a guideline, and I'm not going to bore you with all the different steps here, but I'm just going to go into a few of these aspects. One of the things that is important are the asking the right questions, and those are these PICO questions. You might have heard this earlier when one of my colleagues spoke about the POI guideline, and I think Cindy Farquhar also spoke about this earlier this morning. So PICO meaning we're asking about patients or populations, what intervention has been done, what comparisons are made, and what are the outcomes. So for example, from one of the ESHRE questions, in women with endometriosis, so the patients, is surgery, meaning the intervention, effective to increase, that's a comparison, the chance of natural pregnancy. And for the guidelines, we had 35 different PICO questions, and then 7 narrative questions where we found that there was no proper way of asking a PICO question. when we then look at the quality of the data, we have to look at different forms of biases that are possibly involved in the presented data. So selection bias, were patients randomized properly, were patients or the different arms, were the patients or the people who do the intervention blinded, what did they do if they had a loss of participants, so how was that taken into account, etc. And then we use the grading system, the grade system. And as I said earlier, randomized controlled trials are usually the highest quality data that's available, or higher, apart from systematic reviews, whereas observational studies are usually regarded as relatively low quality data. But with the grade system, you can also see that randomized controlled trials can be downgraded in their quality. So for example, if there's a risk of bias or inconsistency, etc. On the other hand, if you have good observational studies, there are also factors, if there are large studies, for example, and there's a dose response, for example, looked at, etc., where you can increase the quality of the data as well. And then grade then has this categorization: high, moderate, low, and very low quality data. And that's what we used then for the ESHRE guideline as well. So if you have a high quality data, then you are very confident that the data is probably correct, whereas if it's very low, then you're quite skeptical about this. Now, what is very important when you write recommendations, there are certain ways of wording this, and this is quite important and quite central to all of this, because if you have a strong recommendation based on good quality evidence, then the wording is something like, it is recommended, do this and that. Whereas if there is no good data, then the wording should be more, well, it is suggested, or you may consider this. And this is really central to this, because if you read a guideline, just because there is some guidance on a particular topic does not mean, yeah, ESHRE or ASRM or so said, yeah, there is something there. You really have to read, well, between the lines and the lines to see how good or bad that quality is and how strong is really the recommendation. So what are the data actually from the ESHRE guideline? So from all the different questions we've had, there was not a single one where we would say there was high quality data for all of endometriosis. So not a single study or a group of studies where we thought this would really give us a very strong recommendation. There were 8 for a moderate quality, but the majority of these studies were of low or very low quality. And that's not really our fault. It is the issue that it is indirectly because we do the studies, but from a guideline perspective, we could only use what was available. So the vast majority of the data are relatively poor. As a result, we also gave 30 research recommendations. We could have given more, but we were stopped by ESHRE because otherwise the volume would have been probably twice the size. So how about the quantity of the data? So for example, I think everybody here in the room who has dealt with endometriosis patients would have given the patient some form of, ibuprofen, naproxen, etc. So non-steroidal anti-inflammatory drug, because we all think it helps the patient, etc. But if you look actually at the data, this is based on a single study from 1985. Doesn't mean that it's bad just because it's been 40 years or so, but a single study with 20 patients, double-blind study, crossover, where 20 patients received for 2 cycles naproxen or placebo, and then after 2 cycles it was switched over to the other treatment. And it showed that naproxen had a complete or substantial pain relief in 83% and placebo 41%. So we're treating 190 million women with naproxen, for example, based on 20 patients. So if you're sitting in the guideline group and say, well, what do we do with this? Are we going to say, well, don't give naproxen or non-steroidals just because we don't have a big study? You could say that. Or you look a little bit beyond, and what we did was we looked at primary dysmenorrhea, which per definition has nothing to do with endometriosis, but we argued that because of the diagnostic issues that we have with endometriosis, where we often don't know whether the patient has endometriosis, probably a lot of patients who were diagnosed with primary dysmenorrhea may actually have endometriosis. So we extrapolated from that as well. And there are some data to suggest that non-steroidal anti-inflammatory drugs may be of benefit, even though you see the quality isn't fantastic either from those studies. How about transferable standards? So with our recommendations that we give, is that applicable to everybody in every country and at every setting as well? So is it transferable to the real world, as we call it? And we got a lot of flag from this part on diagnosis. So in the first ESHRE guideline, which was published in the, I think in the 1990s, 1998, I think, if I remember correctly, which was taken over in the second version of the guideline in 2005, there was this dogma that you have to do a laparoscopy to identify or rule out endometriosis, and that's the gold standard. And everybody who publishes on endometriosis uses this and cites this as well. Now, what we did in the new guidelines, we looked at the data on other forms of trying to identify or rule out endometriosis, and we came to the conclusion that you don't necessarily need to do a laparoscopy for endometriosis as the gold standard, but with that's not true for all of endometriosis. So it's true probably for ovarian and for deep endometriosis, but again, coming back to the standardization and transferability, is it true for every every endometriosis center? So is ultrasound quality good in every endometriosis center? So the gold standard question initially was coming from a systematic review published in the British Journal of Obstetrics from 2004. 4 studies involved, 433 patients, where they found a specificity of 79% and sensitivity of 94%. And that's what then people used also in the Cochrane reviews. Then that came from that as the benchmark to say, for example, biomarkers, are they good or bad compared to the diagnostic laparoscopy? They also used this in the systematic reviews. You might remember in 2016 there was from a group, or groups, I guess, in Australia and New Zealand. They looked at different things, biomarkers, imaging, etc., and they looked at the data from ultrasound scans and from MRI. And you can see that for transvaginal ultrasound scan and transvaginal and MRI for ovarian endometrioma and for deep endometriosis, the sensitivity and specificity was very similar to what the laparoscopy had shown. If you look at endometriosis overall, so for superficial disease, the numbers were definitely worse. So if we go back to this, can we then now say every patient who's having an ultrasound scan and where endometriosis was seen or not seen, the disease can be ruled in or can be ruled out? So is the ultrasound scan in every place as good as in these centers which publish these papers? And that is always a big issue to remember. So the guidelines suggest that clinicians are recommended to use imaging, good ultrasound or MRI in the diagnostic workup, but they need to be also aware that negative findings do not exclude endometriosis. And that's where a lot of patients initially were quite unhappy with us because they thought, oh, here are again some gynecologists who take away our laparoscopy, and we're not having, we've been waiting for many years and now we're not having any laparoscopy anymore. So you have to really distinguish this, and you have to discuss the pros and cons with the patients and the limitations of the imaging that you may have locally as well. And then finally, how about accounting for the disease heterogeneity? So we still divide endometriosis surgically in ovarian and deep and superficial endometriosis, but does that really reflect the biology of the disease? I would argue probably not, because otherwise I would think we would probably be better managing it, and maybe we wouldn't have as many recurrence rates, maybe we wouldn't be treating or over-treating or under-treating patients. This picture on the right-hand side is from Dr. Gidice's New England Journal paper from 2010. What we use often is the ASM classification, 1, 2, 3, and 4. Patients actually use it as minimal, mild, moderate, and severe disease. Whether that's a good idea or bad is another question, because that also suggests the severity of their symptoms. So they often are unhappy if you say, you only have minimal or mild disease, because they think you're not representing the severity of their pain. But for example, if you have a stage 3 or 4 disease, according to ASM classification, you could either have a frozen pelvis, obliterated pouch of Douglas, and therefore it's counted as stage 4 disease. But you could also have some endometriomas with some adhesions, and again, you get the same classification. But you can also have superficial disease at different places. And we all throw this in the same bucket, and I would argue probably deep disease, superficial disease may be, in some cases, different. So there is, however, some good evidence as well. So for example, which patients need treatment with assisted reproductive technology after surgery? And as you heard just before, and I tell this to our registrars as well in the operating theater, this is actually one of the few things where we had pretty good data. This is from David Adamson's paper from 2010, the Endometriosis Fertility Index, where at the end of surgery, you look at the least function score of the ovary and the tubes, look at also the history, and then you come up with the EFI score. And then, as you again have seen before, you can tell the patient if she's trying to conceive, how likely is it that you will get pregnant over what particular time. And that is something that you should use to consider trying to conceive naturally versus potentially going through IVF or similar. The reason why I'm saying this is good evidence is because actually this has been independently validated by 2 groups in other countries as well. So I think this is relatively strong evidence that we have. Another thing that was just mentioned before, how about fertility preservation, especially in endometriomas? We know that when we do surgery on endometriomas, we do reduce AMH levels, and if we assume that the AMH level represents the ovarian reserve, we may be doing something bad for these patients if we treat endometrioma prior to them becoming pregnant. And the recommendation for this is that in case of ovarian or extensive ovarian endometriosis, we should discuss the options of fertility preservation with a patient with the pros and cons. But this is really based on 1 or 2 studies, primarily on Anna Kobo's study from 2020, where they looked at fertility preservation from, I think, 485 patients or so. And then they looked at what happened and how many patients became pregnant when they came back. I think about 46-48% of the patients came back, and they had good live birth rates, again in the range of 45%. The criticism there was, however, that those patients came back very quickly. So after a year, year and a half, I think was the average time. So the question was whether this was really proper fertility preservation or whether this was part of the fertility treatment as well. So we are relatively careful with the wording there. There's also changing evidence. For example, what we used to do is, in the old guidelines, based on a Cochrane review at the time, that we should downregulate patients for 3 to 6 months with a GnRH agonist to improve IVF success rate, because there were data at the time that IVF success would increase by about fourfold, so enormously, really, if you did this. The new recommendation doesn't do that anymore because there was an updated version of the Cochrane review. And what we found in that Cochrane review was that there were 2 studies that had previously not been published. We actually contacted the groups and saw that the data is not as good as it seemed initially, and really has taken away the recommendation from let's consider doing this, to be careful, because we don't really know whether there's any benefit in doing so. I'm not going to go through all the guidelines. You can look this up in the document. There's also a patient-friendly version, and the guideline is also available in different languages as well, not in Japanese yet. But I think this will be quite helpful. So in summary, I think we all learned that in medicine, nothing beats experience, but good evidence, really. So I thank you very much, and happy to take any questions.
Are there any questions?
Ethan Barnea from United States. We are both moving now more and more to less surgery, to minimally invasive, to no invasive. So what I see is that you do not mention any medical treatment that maybe Esri recommends, like progestinic age, etc., to go before advancing to a surgical approach.
Yeah, so I didn't go into that bit because I was more focusing on fertility given the audience, but the data suggests that there's probably no benefit in treating medically to improve the outcome of surgery. There are some data now to suggest that if you do surgery, add some form of hormones afterwards if the patient is not trying to conceive afterwards. And that's what a lot of people do. They put a Mirena coil in or some other form of medical treatment afterwards. But the data is not very strong, to be fair.
And prior considering surgery?
Well, not in order to improve surgery. We would not recommend that at the moment. I know in the old days, people would give 3 months of GnRH agonist or so prior to that. We don't think that the evidence for this is very strong to make that recommendation at the moment.
Thank you.
Yeah, thank you for your presentation. I'm from Vietnam. So the new guidelines from Australia, you said, it's not recommended to use GnRH agonist 3 to 6 months prior IVF because it's not strong enough. But for the case of the adenomyosis and the repeated implantation failure with endometriosis patient, so what do you think about this case?
Yeah, so that's a good question, and it comes back to probably opinion rather than proper evidence. You're right, endometriosis and adenomyosis are probably often seen together. There are now some data, especially with the GnRH antagonists that are coming on the market, with very, very few patients, however, to suggest that you may be able to reduce the size of the uterus and I guess the adenomyosis and therefore the uterus. Whether this really translates into better pregnancy or ideally live birth rates remains to be seen. I think we need to have large and larger studies to show this. I think most IVF, or a lot of IVF units are considering downregulation prior to putting an embryo back if there's significant adenomyosis. I'm not sure whether it's based on very strong evidence yet.
Thanks.
Professor Moll.
Ben Mol, Monash, Melbourne. Thanks for that excellent overview. BMJ this weekend reported on research integrity. You didn't touch upon that. I just want to comment on that. That's not my question. My question is, millions of patients and so few trials. What is wrong? And it's a question to all of us with our system that we are not able to create better data.
I fully agree. Thank you, Ben. It is a big problem. I think it's a matter of, well, I think for a lot of years it was a matter of ignorance with endometriosis. I think with the onset of social media, things may improve, and that's one of the very, very few things that I like about social media, I must say, that we now have patients being more active and approaching us and putting us under pressure, and hopefully politicians as well. You've seen in France and in Australia, as you know very well, there is now money being put in, but it's very, compared to the amount of patients that we have, not enough. And as Dr. Jadis knows very well, pre-new administration, there was already very little funding for endometriosis-related research compared to other equally prevalent diseases, and we'll see what happens now anyway.
It's not embryo research, so hopefully it will be in the safe zone. Yes, another question.
Yep, I'm Dr. Kitajima from Fukuoka, Japan, and considering the previous question about the ART treatment in endometriosis and adenomyosis, I think the segmented art, the cryopreservation, and frozen embryo transfer is improve the pregnancy rate in women with endometriosis and adenomyosis. But the problem is the obstetrical outcome may be worse where we perform the cryopreserved embryo transfer or even hormonal replacement endometrium preparation. So what is your view from the guideline to suggest the women with endometriosis or adenomyosis to perform the cryopreservation embryo transfer with hormonal replacement therapy?
Yeah, so in that last guideline from 2022, we did not address that particular question. So that is something that, a possible question for the next round of guidelines. And because the data that was collected for the last guideline finished, the data collection I think finished end of 2020. We're now almost, getting to 5 years, which means the new cycle will start next year. That is definitely something that we will have to look into, because that's a very important clinical question.
Thank you. I'm looking forward to your next version.
And the other thing that we will try to do as well, I mean, obviously these are all doctors, I would assume, from secondary and tertiary care. One of the things that we probably have to address more is how do we take into account primary care as well, because there are, the ESHRE guidelines are very much focused on hospital care, etc. So we may have to be a bit broader than this as well.
Thank you.
So I have a question for you. It's not directly related to guidelines, but as non-invasive diagnostics are, I think, soon to be here, hopefully, the ones that have been trialed seem to have no distinction for the different stages of disease or types of disease. And so as you look ahead, how might you see this impacting care? And maybe this is something for the guidelines 10 years from now for the next, maybe the 4th or 5th revision.
You mean how the current imaging will, or investigations will improve things, or?
The imaging, I think we have basically for endometriomas and deep infiltrating disease is, I think, quite robust. But in terms of the circulating or salivary tests.
Yeah, so as you may know, there has been over many years interest in different biomarkers. We both looked at this. So far, again, and that's also what the guidelines from 2022 say, there's nothing there that is clinically sound yet, because nothing has been done in large enough studies to confirm this. One of the things you are referring to is the saliva test that has been published now twice, as far as I'm aware, unless something happened recently, where a group looked at microRNAs in the saliva of patients with endometriosis. And in Switzerland, for example, it's been available through the National Health System. In France, there's some debate about this. I just had a discussion with Professor Armand about this as well. The thing is, if we offer something to the patients, we need to be as certain as we can be that it is good. And if we publish something early or too early, because, for example, we are a small company, and I'm not only saying this for this particular product, there are other products out there as well, and we publish something early, patients who are desperate, as we all know, will come and buy the product if it's available. They pay any money that they can get together. And then we may have a bigger problem if eventually larger validation studies show that the product may not be as good as initially thought. And that is something that we have to be aware of. So I think before we recommend something to the patients, we really have to have large independent validated studies before we can really recommend this to the patients. Because if we don't, patients will get upset. We might mistreat the patients, which is even worse. And they lose confidence in us even more. So that is something to remember.
Thank you. So thank you very much for your presentation.
Okay, the last speaker is Professor Olaus Roman. Is good, right?
Thank you very much. Ladies and gentlemen, Mrs. and Mr. Chairman, dear colleagues, it is a great pleasure for me to be with you in Japan and to discover this wonderful country, which is Japan. And even though I have a very difficult task to try to sell you the surgery, you, in majority, your IVF AORT specialist. But let's try to see which patient may benefit from the surgery if they are involved by severe advanced endometriosis. So here are my conflict of interest. They are mainly fees I received for organizing training, surgical training for different companies. So when you speak about severe endometriosis, we have a lot of studies. Most of them focus on colorectal endometriosis, which is the most frequent severe form of endometriosis. And inside we may find patients who are infertile and patients who simply wish to get pregnant, but they have a very severe endometriosis. And the endometriosis is a problem in this patient because the mean age of deep endometriosis surgery is around 30 years old, and this is the age of the first pregnancy in Occident. So the question is how to manage the pregnancy intention. So again, the patients with severe endometriosis may wish to get pregnant without having a documentation of the infertility, or may be infertile because they are stage 4, where the probability of pregnancy is very low. So to recommend, to tell you that you have to do the surgery in these cases, I have to prove you that my surgery will not decrease the rate of pregnancy if you carry out an ART after the surgery, or it is balanced, this decrease is balanced by an increase of the rate of natural pregnancies. And also, I can support the surgery by the improvement, a general improvement of health of my patients. So this question is very, very, very frequent in my daily practice because I am involved exclusively in the management of deep endometriosis. So the patients say, I have severe endometriosis, I want to get pregnant, and they ask an advice. If we go back to guidelines, so they were in a brilliant manner presented by Christian, the patient will say, what should I do? I have to go to the IVF or I have to have a surgery. So I answer them, both strategies may be considered. But in the past guidelines, there was mentioned that as we do not have randomized trial comparing the IVF to the surgery, we cannot definitively state which is the best way to treat the patients. And the guidelines say the patients may have surgery if they have pain. And this word pain is somehow embarrassing for me. Because if you refer to the surgeon only patients who see for the ART, and you refer to the surgery only patients who are pain, you can miss some patients which actually need a surgery without being very painful. For example, there are patients who wish to get pregnant but cannot have sexual intercourse because of the pain. Of course, if they do not have sexual intercourse, they are not painful. So this symptom, which is which has a huge impact on the fertility of natural conception, may be overlooked. So these kind of patients with big endometriosis who cannot have sexual intercourse, I think the surgery is required. Then there are patients who are not painful, but they have a lot of difficulties to void the bladder, to empty the bladder, because they have endometriosis of the parametria, which involve the splanchnic nerves of the bladder. For me, this symptom is terrific because the patients may be destined to have self-catheterization in the long run. So these patients, I think, should be referred for a surgery. The patients who are not painful, but they said, oh, I have a bloating, I have a huge belly, everything, ask me if I am pregnant. This patient may have a very severe bowel endometriosis, even not very painful, but in this patient, I advise the surgery prior to IVF. The are typical, unpainful but very severe endometriosis is the deep endometriosis of parametria, which is responsible for a stenosis of the ureter, which may lead to silent kidney. Silent means there is no pain. So these kind of patients should be referred to the surgeon prior to the IVF. And I used to do routinely nephrectomies in very young patients where the kidneys are completely destroyed by endometriosis. And last but not least, there are patients with huge endometriosis, but outside the area where the radiologists have or used to look at. So the patients with endometriosis of the sacral plexus, of the sciatic nerve, which have sciatica during periods, but nobody worry about endometriosis. Everybody look at the spine. This patient should be referred for the surgery. My colleague spoke about the endometrioma. So having endometriomas and the risk of surgical impact, negative impact on the ovarian reserve, this is not an argument not to propose a surgery for deep endometriosis, because we can simply drain the endometriomas and remove the deep endometriosis. We can treat them by vaporization, by sclerotherapy, an excellent technique which was born in Japan 40 years ago, and we routinely use in Bordeaux. And it is not mandatory to perform the cystectomy in these patients. Take care about deep endometriosis first. Now, the patients will say, okay, what is the pregnancy rate I can expect if I go directly with my rectal endometriosis, if I go directly in the IVF? And we have some data about this. I can answer them as about 70%. And we have 2 French studies where my colleagues, who are also friends of me, they looked at the pregnancy rate in women with severe colorectal endometriosis who were sent directly to the IVF. So they observed that they may expect 70% of pregnancies if the patients have up to 4 IVF. But they also observed that the first and the second IVF are responsible for almost all the pregnancies, while the third and the fourth IVF simply increase by a minor, are responsible for a minor percentage of pregnancies. But we can expect if everybody goes up to 4 IVF, which are reimbursed by the government in France, they may expect 70%, up to 70% of pregnancies. Now the question is, okay, but if I go to the surgery with you, what is the pregnancy rate I could expect? And I can answer her, yes, up to 80%. And I have arguments for this because 10 years ago I carried out the unique randomized trial comparing in women with colorectal endometriosis, comparing the colorectal resection to the conservative management by disc excision or shaving. And these women were followed up to 10 years. So now the article about 10 years follow-up is submitted in GMIG. So these patients had the surgery for colorectal endometriosis. But as they were young, they tried to get pregnant after my surgery. So I could observe that in women who wanted to get pregnant after my surgery, the pregnancy rate was 81%, a majority of them being pregnant naturally. And if I look at only women who were infertile before my surgery, but they went to the surgery because they were too painful or too symptomatic, in this case, in only this subgroup of infertile women prior to the surgery, the pregnancy rate is 74% with a majority of natural conceptions after the surgery. So this study for me is the proof that the surgery has a benefit on natural conception. And furthermore, in France there is an idea, a folk that if you want to get pregnant fast, you have to go to the IVF. So I look at my patients after when they decided to get pregnant and they stopped the pill, who is pregnant earlier? The patient who tried to get pregnant naturally or the patient who had IVF? And I observed that the patients who were pregnant naturally earlier, and I emphasize the role of the EFI score, which allows to the surgeon to advise after the surgery to the patient. So I tell them, you can try to get pregnant for 9 months, or you have to not stop the pill and go directly to the IVF. So the patient will say, okay, you spoke me about studies done by your friends with the IVF and your data in surgery, but do you have a study which compare in the same population, in the same center, women who had IVF and women who had surgery? So unfortunately, we do not have randomized trial right now, but we have retrospective studies using the propensity score. This is the largest one, which observed that women who had the surgery before the IVF could expect better pregnancy rate than women who had IVF first with the deep endometriosis inside. And on the basis of several studies like this, there are 2 randomized trials ongoing right now in France and in Denmark, and I am actually involved in both of them. So we compare the IVF and the surgery. In the first trial, effort randomized trial, we compare the IVF first to surgery followed by natural conception attempt or IVF after the surgery. In the other one, Endometriosis, which is a French multi-centric study, we compare the IVF to the surgery with mandatory IVF after the surgery, meaning that in this second randomized trial, the patient cannot try to get pregnant naturally, they have a pill after the surgery. The problem is that the enrollment, and I answer also to my colleague who asked why we do not have enough randomized trial because it's very, very difficult to enroll the patients. Because when the patient came to the surgeon, they have already had 2 or 3 IVF. They said, I don't longer want to hear about randomization or IVF. I want to have the surgery. If I came to see you, I want to have the operation. So that's why we work for this randomized trial, but the enrollment is slow. So the conclusion will be within 10 years. Now, some patients started by IVF, and after 2 failures, they ask if it would be interesting to have the surgery to change something. And we have a look in our personal series of women having the surgery after 2 or more IVFs. And we observe that if we perform the surgery and then, depending on the EFI, we let them the chance to try, the opportunity to try to get pregnant naturally, or we refer them for IVF, the pregnancy rate is almost 44%. And I think it is better than data observed by my colleagues who carried out the IVF without surgery, where the 3rd and the 4th IVF was responsible for 10% of exceedance of pregnancies. That's why in our daily practice we propose a surgery for deep endometriosis in women who have 2 failures for IVF. Now, if the patients do not go directly to the surgery, it's because someone tells them you have a very severe endometriosis, the surgery is too difficult, the risk of complication is scaring, and the patient is frightened by this. So is the postoperative complications rate so scary in order to avoid the surgery? So if we look again to our data, we perform 300 colorectal endometriosis a year, so we are experienced. But we cannot avoid postoperative complication. This is an evidence, it's obvious. And we have 3.4 fistula. The fistula is the most terrific complication after a deep endometriosis. All the patients said, will I have the stoma or not? So we have 3.4%. We have also pelvic abscess, but they are much easier to treat. And this should be put in balance with what I have already said. 80% of pregnancies with most natural conception is very important, because if you refer the patient for IVF, there is no natural conception. With the long-term improvement of pain and quality of life, 10 years after the surgery, patients enrolled in the randomized trial have a constant improvement of their quality of life, and the very low rate of colorectal recurrences after the surgery. If the surgery is well done, only 5% of patients will recur 10 years after the surgery. And if you look to only patients who have a complication, this is not the end of the world, and this is not everlasting infertility. Because we had a look at in 3 centers, we checked the patient who had the complication with a reoperation after the first surgery, and we observed 42% of pregnancies. So it is less than if they do not have complication, but it's still correct. Now, the patients with low ovarian reserve. The low ovarian reserve is frequently an argument against the surgery. The problem is that patients with low ovarian reserve will have worse results in IVF because the ovaries will not answer. So I think in patients with low ovarian reserve, there is maybe the population of women where we have to fight to help them to improve the natural conception. And we had a study where we involved all the patients who had the surgery for severe endometriosis, and we analyzed the results depending on the preoperative AMH. And you observe that even in patients with AMH less than 1, where the surgery was done because they were painful or there were clear indications for the surgery, the postoperative pregnancy rate in women who attempted to get pregnant was 68%. But you observe that the lower the ovarian reserve, the higher is the percentage of natural conception and the lower the percentage of ART, meaning that in low ovarian reserve, as you know, the ART works less than in women with normal ovarian reserve. So it is not forbidden to perform the surgery for severe endometriosis, complex endometriosis in women with low ovarian reserve if arguments exist. But we can also ask differently. If a patient has a very severe endometriosis with a lot of involvement of organs, is it always safe to refer her for 1, 2, 3, or 4 IVF hyperstimulations? And these questions was assessed by the team of Cochin Hospital, who stated, no, the patient who have endometriosis and hyperstimulation are not more painful after the stimulation than before. So performing the IVF is safe in patients with endometriosis. Okay, these data were confirmed by the colleagues from Denmark. But if you look at the population, the women are not very painful at bedside. So if you take the overall population of endometriosis, you can do IVF. This is not a big problem. But if the study done by the same Danish team focuses only in women with colorectal endometriosis, by 13% of cases, meaning 1 patient out of 7, they had to stop the hyperstimulation because of the pain of patients. They had 2 patients with occlusion during the hyperstimulation and 6 patients with subocclusion. This patient had the surgery, and after the surgery, 6 became pregnant, among which 1 naturally. So take care with the hyperstimulation in patients with very severe disease involving the rectum with bloating. In my daily practice, where the patients come after IVF, I used to ask them, do you feel that the IVF impaired your symptoms? And in very frequently, they said yes, there was a before and after the IVF. I cannot tell you that the IVF was responsible or simply stopping the amenorrhea to perform the stimulation is the main factor, but trying to get pregnant with a severe endometriosis usually impair the symptoms. And we also carried out a study where we try to measure, to estimate the risk of the growth of the nodules. And we focused only on colorectal endometriosis because it's easier to measure. A rectal nodule has a length and a thickness. So it's easier to measure than a nodule of the parametrium. And you observe that in women, during 3 years, women who are not in amenorrhea, meaning who try to get pregnant either by IVF or naturally, in 40% of cases, there is an obvious increase of the nodules. So the disease may progress during the pregnancy attempt. Last but not least, sometimes when I performed the surgery, I said, oh my God, if my colleague who performed the ART had been aware about this pelvis, I'm sure he would not have not put the needle inside, because usually the ovaries are above the rectum, so there is actually a risk of injury of the rectum during this punction, while after the surgery you have this kind of pelvis, so it's safer. Now, after this talk, I would be very happy if you keep on mind that the surgery does not impair the fertility. So if you can rule out this fake news, which is the surgery renders the patient infertile. But it does not mean that everybody should go to the surgery. So I think that the management of endometriosis is a custom-made management. It's not a pret-a-porter. It's a custom-made management. The problem to speak together is that we are usually around the patient 3 specialties with different angle of view. Me, I am surgeon, so I have a high prevalence of severe case. So behind each patient, I see the risk to progress to a very, very, very severe surgery and a lot of complications. So maybe I push to the surgery in advanced endometriosis. The colleagues with ART have the experience of very successful IVF, high-rate pregnancy, so they say, we can go to the IVF, it works very well. While the gynecologist or the GP, who sees very, very rarely the patients with severe endometriosis, say, no, 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 it's not a problem. The endometriosis is not a problem, it's in your head. So that's why it's very difficult. The patient may be confused in this triangle. That's why the multidisciplinary meetings are very, very useful, but the multidisciplinary meetings should involve people who have experience in this disease. So if anyway you have a patient with severe endometriosis, if you want to go to the IVF, to propose the IVF, because you do not have a surgeon for various reasons, my advice is to start by assessing the disease, to see where the lesions are, their size, their severity. Then ask the advice to an experienced surgeon. Because if you ask the advice to a non-experienced surgeon, you say, oh, don't touch her, it is very, very difficult, the huge risk of complications. So ask the advice to an experienced surgeon. Then adopt custom-made management, and if you do the IVF, you can leave an amenorrhea, because anyway you have to block the ovaries before the stimulation. So give her a pill between 2 stimulations. And of course, don't push your luck too far in order to avoid complications such as occlusions or bladder dysfunctions. So thank you very much. And so I arrived in Japan 10 days ago. That's why this morning I added this with my family. So I'm the first time in Japan. That's why I added a last slide where I said thank you to Japanese colleagues and people for being so kind, so honest, so respectful, so hard workers, and for making the life in Japan so safe and pleasant. And I think that you should be a model for other people.
Thank you so much. とてもありがとう。Dr.
ありがとうございます。
Any comment?
Wonderful talk, thank you. I have a question. I'd like to ask your opinion, the mechanism by which the deep endometriosis resection has a favorable effect on fertility.
But about the bowel?
Bowel, yes.
Yeah, but this is the goal of the 2 randomized trials, to assess if the complete treatment of the endometriosis by bowel resection or complete shaving or disc excision has an impact on the IVF. And both randomized trials are based on a hypothesis that in the arm of patients with surgery, the pregnancy rate will be higher by 15%. So both randomized trials have this hypothesis that it works better if you perform the surgery. But of course, as you clearly specified, if the surgeon removes the endometriosis but also kills the ovaries, of course the pregnancy rate will be very low. So we have to dissociate the treatment of the deep endometriosis, which should be complete, to the treatment of the ovary, which should be individualized on the basis of the ovarian reserve.
But why, I mean,
why it happens?
Yes.
Which is the explanation. But we don't know, but maybe, I think all this environment of disease and inflammation, and of course we do not speak about hydrosalpinx. I think all these factors are an unfavorable unfavorable environment for the pregnancy, for nidation, and for all this.
So the quality of egg improve, or the endometrial environment getting better?
Either the egg or the local conditions for the uterus to receive.
Okay.
Because sometimes the egg are based on the preservation on the oocyte retrieval before the surgery. So the oocyte or from the pelvis with endometriosis. However, the pregnancy rate looks
So the uterus
looks
is
higher.
Okay,
This is based on retrospective studies. Maybe it is possible also that the randomized trial showed there is no difference.
Thank you. Interesting.
Coming back to what I said also earlier about the standardization or the transferability of data, when you have your, when you do studies with rectovaginal disease and especially fertility, how do you ensure that, well, I would assume that patients who have tubal disease, ovarian disease, are probably slightly different to those who don't have it in rectovaginal disease only, so to speak. So how do you put them into studies, or do you separate them? So
no. So in studies, retrospective studies, which are actually prospective, because we record our data prospectively. We have a database, prospective database. Of course, in this case, we'll just make an adjustment on multivariate analysis. That's why it is important to carry out a randomized trial where all these other factors of infertility are balanced by randomization between the two arms. And in this case, we'll have the answer if there is a difference depending only on the surgery. But otherwise, the problem of endometriosis is the heterogeneity. So, and then there is also the sperm. It may interact. So it's there are a lot of confusion factors. That's why from this presentation, what I want the take-home message is that the surgery is not dangerous. The surgery may improve the fertility rates, the pregnancy rate, and it can be done before the IVF without harm. It can also be harmful on the ovaries. But then it's a custom-made management where we have to handle. Of course, we record when we decide in our multidisciplinary meetings. We check everything, including the sperm qualities, and in order to take the best choice, the choice who seems to be the best.
One more question. Yeah, please.
Yeah, thank you, Professor Rahman. I really enjoyed it. Ben Mol from Monash again. As you challenged me, I'm going to challenge you. The field with the most progress in medicine is child oncology. And the reason is that in that field, they have done trials, and trials. Now, I cannot believe that if you're able to let your child with one life randomized for 2 different treatments, that we cannot randomize women with endometriosis. That issue is not with the women, it is with us. And with the funding that now is available in France, and congratulations on that, and in Australia also, I think we really have the obligation to do these trials. I'm sorry to confront you again. I'm Dutch, so that's a little bit my style. I apologize for that. But if you like Japan, because everybody is so nice to each other, then we have the obligation to be nice to our patients, and specifically the patients in the future. That's my comment. And I really look forward to the outcomes of your trial.
Yeah, I fully agree with you.